Today, I'm going to talk about PCOS. And just like Khadija said, I think from what Alameen has already shown us regarding obesity, this is a common theme that we see with our obese patients. But this is an overview of what I'm going to talk about. I think if you look at the history of PCOS, everybody is familiar with Stein and Leventhal, and that's what changed or who were the first who introduced us to the PCOS. But saying that, it was actually an Italian neuroscientist who first described it in an Italian woman who were finding it difficult to actually conceive. And they saw the string of pearl picture on the ovaries, and that's where the first description came. And his name was Wallisani. And that is the first description that you see of the polycystic ovary. I'm going to focus today really on the international guidelines. Everybody is familiar with the criteria, which is the Rotterdam 2003 criteria, and the NIH that we normally utilize to make the diagnosis of PCOS. I'm just going to take you through the international guidance. This has just been published this month, and the focus is a little bit different from what we are familiar with. So just going to take you back to a case that I saw in the clinic. I think we all see these cases in our clinics. 33 years old, Polish, who was referred by my dermatology colleague because she said she has acne and really suffering from it, but it is in odd places. So it's not just on the face, but it's on the neck and her back and shoulders. And the question was, is there any underlying hormonal imbalance or hyperandrogenism? She did not have any hirsutism, periods were regular. So the question is whether this patient has PCOS or not. So how do you define PCOS? Actually, 5 to 18% have been described to suffer from it in literature, but I think this is an underestimation as well. It is a reproductive, metabolic, and psychological condition which actually impacts throughout the lifespan of a woman. So what is the underlying pathophysiology? So it is quite complex, just like we heard about obesity. PCOS actually is not straightforward. It is quite complicated. And genetics and epigenetics play a big role. That's what we are discovering now. In addition to the hypothalamic ovarian dysfunction, along with underlying insulin resistance, and also there are several adiposity-related mechanisms which we are still understanding. In the last decade, there has been a big shift in looking at genetics of PCOS. And at the moment, there are 19 foci which have been identified, which actually increases your risk of developing PCOS. And some of these foci are like FSHB and R. What they do is they increase or affect the gonadotrophin flow and cause an excess, which causes the androgen excess. And later along the pathway in the androgen synthesis, there are some genes which are involved. So it has really changed our understanding of PCOS. If you look at from the hormone point of view, which we all do because I'm an endocrinologist, the underlying problem is hyperinsulinemia because there is underlying insulin resistance. What it does is it acts on your higher function of the brain, especially the hypothalamus, increases or changes your LH to FSH ratio, but it also increases the anti-Mullerian hormone. And what it does is it does affect the ovaries and it causes a follicular arrest. And that is the reason we get oligo or amenorrhea. Then if you look at the other side, the underlying insulin resistance, what it will do is it will affect the liver and it increases the free fatty acids. And that's why your adipose tissue plays a big role in it. It can cause hyperglycemia. And this is the reason you see that there is a reduction in the sex hormone binding globulin. And what it will do to the ovaries is it will increase the androgen levels. So if you keep this slide in mind, I think the rest of the slides will make more sense then. So how can we diagnose PCOS? I think we are all familiar with the Rotterdam criteria where you have to fit in 2 out of 3 criteria. But this current international guidance has moved a little bit away from it. And this is just published in by the Endocrine Society of Endocrinology, and it is also approved by the Endocrine Society in the USA as well as the European one. So the step one is, does the patient have irregular menstrual cycle? And whether the patient has clinical hyperandrogenism. So both those two together, if you have it, you have got your diagnosis. Then you don't need to move to step 2 or step 3. Let's say you have one of them, then you go to step 2, because if there's no clinical hyperandrogenism, then you look for biochemical hyperandrogenism. And I'll explain all of this in the next slides. Only if you have got one of those two features, that is the only time when you need to think of pelvic ultrasound. And it is quite clear, and I think it's especially true in this region, we should not be considering the pelvic ultrasound for adolescents because it's not recommended. You should keep it that these are at high risk of PCOS and reassess. At the step 1, also consider your other pathologies, which can be the reason for the irregular periods, whether it's your hypothyroidism, Cushing's, any adrenal tumors, or hyperprolactinemia. Once you have ruled that out, then you go from step 1 to step 3. Let's look in detail, what do we mean by irregular cycles first? So post-menarche in the first year, it is actually normal to have irregular cycles because the gonadotrophins are pulsatile. It's not a continuous secretion of the gonadotrophins. And that is why for the first year, the cycles can be irregular. It does not mean that that adolescent has a problem. So you only look for that if primary amenorrhea by the age of 15 years or 3 years have passed post-breast development. That's when you look into if there's a problem or not. And from 3 years post-menarche to perimenopause, if the cycle is less than 21 days or more than 35 days, or in a year, if the patient is having less than 8 cycles, because that is what is needed, or 1 year post-menarche, more than 90 days for any one cycle. That's when you consider this is irregular menstrual cycle now. What do we mean by hyperandrogenism? So when you have androgen excess, clinically, the hirsutism is a much better predictor for clinical hyperandrogenism. If you have that, you can make the diagnosis. You don't need the blood tests. But remember, our patient only had acne, no hirsutism. Acne itself is not a very good indicator for clinical hyperandrogenism. It can be, but it is not very good predictor. That is the reason you look into biochemical hyperandrogenism. And for that, you can utilize either total testosterone or free testosterone. Let's say the testosterone comes back as normal. Is there any other thing that you can use? That is the situation where you can use either DHEAS or androstenedione. DHEAS is very specific for adrenal source, but androstenedione can come from either ovaries or the adrenal glands. But that is how I would proceed next. Then comes the ultrasound, and I think we all see a lot of patients who have been to gynae or somewhere else, and a scan has been done, and the patient comes asking you, do I have PCOS, when it hasn't been looked clinically, and they just have that scan report in front of you. And you just should not accept somebody who has just been reported as bilateral polycystic ovarian syndrome, because you need to know or understand that what is the criteria. So the report is good only if the follicle numbers per ovary has been described or per section. So if you're looking at follicle number per section, it should be more than 10 in one ovary. If it is follicle number per ovary, it should be more than 20. And that is very important. Or you look at the ovarian volume, whether it is more than 10 ml. So this is what has been specified in this consensus statement, that we should not just accept there are bilateral polycystic ovaries. Then the next question always get asked is whether there is any role for serum anti-Mullerian hormone, because several people will do it, especially we all come across cases where these women are finding it difficult to have to conceive or looking at fertility options. And that's when this test is done. On its own, it should not be done. And there is a reason for that. And I'll explain that. But if for some reason you cannot do an ultrasound, only in that situation, yes, you can do it. The reason for that, this is not a good test to do just for on its own and give the diagnosis of PCOS is because it is affected where you are doing it in the terms of menstrual cycle. It is affected by age. It is affected by BMI. And we all find that patients who have PCOS can have high BMI or normal BMI. So it changes according to that as well. So it's quite tricky how you're going to interpret it then. Now that you have made the diagnosis for PCOS, why is it important? It's not only to do with the symptoms or to do with their fertility, but this is a very important thing. We know that patients who have PCOS, it is irrelevant what their age or their BMI is because they can have normal BMI with PCOS. It increases the risk of cardiovascular disease. And that is why this consensus statement has actually addressed it. And what we should do is once you have made the diagnosis, they should have their blood pressure done annually. They should have a full lipid profile, which is non-fasting. And then you need to assess what is their glycemic status at diagnosis. And for this guidelines, they have actually recommended using the gold standard 75 grams oral glucose tolerance test and then assess the glycemic status. If you're not able to do the oral glucose tolerance test, only in that situation, you can use HbA1c to assess the status. And then it should be repeated every 1 to 3 years, depending on what your baseline is. The other risk with the PCOS, and I think that is why it is very relevant to internal medicine, because you see all of this actually within your routine practice. It does increase the risk of obstructive sleep apnea. So once you have made the diagnosis, always ask your patients, how is their sleep pattern? Are they waking up with any morning headaches? There are some good questionnaires which you can use, like Stop Bank score or Epworth score, to make that diagnosis and then refer on to the appropriate sleep medicine specialist. The other risk that they have is because there is increase in the endometrial thickening, lining becomes thick, so there are risk of endometrial hyperplasia and cancer. Remember in the definition, it is a psychological condition, and this is the reason. Because they are worried about their body image, they do suffer from depression and anxiety, and because of that, they can develop eating disorders. So that needs to be kept in mind that PCOS is not only to do with the reproductive or metabolic parameters, there is a very important psychological aspect to it, which needs to be identified. So how do we manage these patients? I think it is not with one specialty. That is the key. So it is patient-centered, multidisciplinary approach. As internal medicine or primary care physicians, they can be a coordinator for the care of these patients, but you need to make sure that the diagnosis is made, you have looked at the complications, and then you address how you can help this patient, because it all depends on the symptoms. If the patient is coming in for fertility, you can't just say, we will give you metformin for 3 months, diet, lifestyle, and that will address it. No, they do need to see the obstetricians early on, so a plan can be made. What do they actually need? Diet and exercise will stay it's an adjunct, it's a lifestyle intervention which can help these patients. But you will see patients where there is normal BMI, where it is not going to help them. In that situation, if weight is an issue, or is it hirsutism, is it acne, is it irregular cycle, what is the patient problem? What are you trying to address? And based on that, that's when you say, okay, does this patient need to see dermatologist? Do they need to see an endocrinologist? Or do they need to see the gynae or sleep medicine at this stage? First of all, I'm going to address the non-fertility features. And I think this is very important to understand that what options does the patient have? Remember, the underlying problem is insulin resistance. So patients who have higher BMI, if you address the weight, the insulin resistance will go down, and that will help the patient in improving their symptoms. If it's the irregular menstrual cycle or it is hirsutism that you're trying to address, then consider the combined oral contraceptive pill. The most common that we use is Yasmin or Yaz because it contains cyproterone in a small amount, and that has anti-androgenic properties. And that is where hirsutism can be helped when you give them the combined oral contraceptive pill. What it will do is it will regulate the cycle and it can help with the hirsutism. Second option is metformin. If you're considering alone, it should be considered in patients who have BMI of more than 25 and they have problem increased waist circumference or increased visceral fat. And that's where the anthropometrics really helps you out. If they have other metabolic problems, like they have already developed pre-diabetes, diabetes, they have got an impaired lipid profile, then you can consider metformin because it will reduce the insulin resistance and help with the rest of the complications. You can combine oral contraceptive pills with metformin. Any patient who's suffering from irregular cycle or with the weight management or they have hirsutism because you're driving the androgens down with it as well. Then the most important nowadays, I would say, we have the tools now like anti-obesity medications, and there are several randomized control trials, although with limited number of patients, not more than 30 to 35, which has shown the use of liraglutide and also recently some papers with semaglutide where they have looked at whether it improves the anthropometric outcomes, metabolic outcomes, it improves the androgens as well. So combination with metformin has proven with these anti-obesity medications that it can help you in gaining that outcome. Then if the patient is presenting just with the anti-androgens, like presenting with hirsutism, you can consider the anti-androgens. Spironolactone is quite safe. You can use from 25 to 100 milligrams per day, not much side effects with it. But if somebody has got severe hirsutism, then you can also consider using cyproterone on its own. But you have to do it, making sure that the patient understands they cannot get pregnant on that. So they have to be on contraceptive. Inositol does not have much evidence. I know it is widely used, but in scientific, if you look at the scientific papers, I've done the literature review and there is not much where it improves any metabolic or anthropometric outcomes for the patient. Bariatric surgery is another thing which we should consider now that we have it, because it does improve your cycles. It does improve the fertility as well. If you look from the fertility point of view and the patient wants to get pregnant, this is the pathway to follow. And that is where the gynecologists and the obstetricians, they come in early in the pathway. So you do your basic evaluation, you provide them with the lifestyle intervention. You can utilize metformin, but then they consider whether the patient needs letrozole as a first-line medical treatment or they need something else. Clomiphene is better than metformin in all the papers it has shown. So that's where the gynae needs to come in early in the management. And then the patient needs to understand that if they need IVF, so then they can provide that information. So in the last minute, I'm going to go back to our case, to this 33 years old Polish lady who was referred from the dermatologist. So if you look at it, she only had acne. Her periods are regular. So we go to step 2. She doesn't have clinical hyperandrogenism. So I did her biochemical androgen levels. Her total testosterone was normal. So that's why she had the DHES and androstenedione, which are normal. And the pelvic ultrasound showed bilateral polycystic ovaries. So her diagnosis is not PCOS. She has polycystic ovaries, but not the full syndrome. And I think that's the distinction that we need to make. Thank you so much for listening. And here are my references.